Fix this. Now give me a scissor. I cut the loop. Look at this. This is something I learned from my mentor, Peter Dolman. You cut the loop. The scrolling suture, no, it's very difficult to fix the knot. It slips. Right? Remove the loop. Now I'll take out the free end. I'm happy with the level. So I'll take out the loop and then finalize it. Any doubts on this? Resection you can almost never do with a single suture. If you're doing LP reattachment with a good muscle, a lot of times you can manage with just one bite, one suture. So I'll take another partial thickness bite. So the suture दिखती हुआ I guess goes with the principle. Whether we are able to do some good or not is another story. Do no harm. Okay, this is okay. Right. So, the more retractor. We see the other central suture. Actually, okay. Tortucci, ideally, to avoid color. ଆପଣ ସବୁ report ଇଏରେ କିଛି କରିପାରିବେ ରିଫ୍ରାକ୍ଟରରେ କରନ୍ତୁ
ଏଇଟା ସେୟାର କରିବେ ଲିଙ୍କଟା କପି କରିକି ହ୍ୱାଟ୍ସଆପ୍ରେ ଛାଡ଼ିବେ ଏବେ ଚାଲିଛି ହାତ କାମରେ ଉଠାଅ
ଏଥିରେ ସିଙ୍ଗଲ ବାଇଟ୍ ସିଙ୍ଗଲ ବାଇଟ୍ ନେଇ ହବ ଯେଉଁମାନଙ୍କର
ଚାଲିଛି
ବଟରେ ବଟରେ ଯାଉଛି
like this.
Right. So that's the second one. Now there is a little bit of a confusion here. This has to come out. This one. Maybe the whole thing came out. Good. Okay. Now the fresh yarn.
ଧରୁଛି ଏଠି ସତ କିଛି କରୁନାହାନ୍ତି ଏବେ
Tarsal bite and well actually last the suture came out, so I'm just passing it again. Okay. Mark. Okay, come to the needle. Okay, सामना कौन है? Right. Is the free end. पड़ेगा. Okay. Pass the second one. Retract. Mark करूँगी. Yes. Say it again. In the same place, we lost the suture, madam. We pulled it, and the whole suture came out. This is actually we are passing it in the same place again because the whole suture came out. I didn't have an option but to pass it again. Now, when I try to do that, take a look at the contour. Okay. So I pass again a loop, and I look at the contour, what exactly I'm getting. That looks okay. So not tighten anymore. I take this out, and because the loop is in this position and I don't want to tighten it anymore, I make sure that my final knot comes exactly at the same spot. I don't try to further tighten it. Usually what will happen if you do that is that you will end up with a temporal flare. So another thing is the central suture is for height. The lateral and the medial ones are for contour. Suture. How good suture darkar hoga tab closure. Now the question is, does one do a nasal suture at all? Is anybody's point for discussion? I would think that we should ideally, at least in congenital, because once she starts squeezing the eye, okay, this contour may go into a nasal droop. Pulling out the. So to maintain that contour, we will give one. Difficult to fast quick one. Modify this I am trying to, if I were not having a double arm suture. See what I'm doing differently. I'm going from the LPS. Okay. Then on the tarsus. Tarsus. You okay? ये नहीं क्यों ना? है कि नहीं? हल्का. ठीक है. ठीक है मार दिया. Distractor. Nasal to the pupil. Okay. Keep on looking at it as I try to tighten this one. Again, do a loop. See? It just stabilizes a little. See that? Now the bump that you see here is because of this suture, pulling this. Right? So I'm bang at the limbus. Okay? Based on the LPS action. Yeah. This? यहाँ पर white fill करता रहो. Keep this out. Okay. Now all the three sutures done. Skin it close करूँ white fill muscle. That's it. As far as LPS. Now, if we were doing this surgery in a patient who is awake under local anesthesia, this was the stage where we would have made them sit up and see the position. Okay? The G, of course. The next step after this is what is called as crease formation. A nice crease. So I take muscle, LPS. Okay? That's the stump of LPS. How does the crease form? Because of LPS attachment, correct? So muscle, LPS, muscle. So why don't you just cut the extra LPS? It's good actually. The stump can be cut, but it would form. But this is a very thin flimsy. It will not cause a problem. You can. If it's a very large one, you can. But here is what is that? I've already removed some LPS. What is that? Orbicularis muscle and skin. Correct. The question is, why didn't I cut the stump of the residual LPS aponeurosis? You can do that. And if it is a very large stump, it tends to show up post-op. But the answer was, I have already removed some skin muscle. And this one is a really thin stump. It's unlikely to cause a problem. Okay. But I think, Alka, the loop is something, the loop that I used for finalizing the suture is something that helps avoid a slippage. Here I'm not sure what I need. Any questions? Cut. Because these sutures I'm taking orbicularis, you need to cut them very short. Otherwise, it will protrude out in the skin. Whereas another way of doing the same thing is you take the Prolian suture and take alternate bites, take the D and pierce thumb. I think that's another way of doing the same thing. So essentially, that completes the fixation, the crease formation. All we have is closure of the skin. Choline, it's a clean grade. So that is the on the table. This is what we have. Okay. I think the position of the eyelid is here actually. It's going a little, and I noticed that she tends to go deviate out a little when she's talking. She fixes with the left. This is also something. Is it pulling the pillow? It does. Mhm. The skin closure is just continuous sutures. Again, because anything can be used for closure, you don't want to bother about um, removing sutures. If the patient is from a far off place, you can use Vicryl, no issues. Most of the time, we prefer choline if we have anyway used it for fixation. But I think one suture that uh, I would say if there is a choice or a preference, then the suture that fixes the tarsus to the muscle. Usually, people would prefer to take choline for that. So we will use a cross suture. And just one more thing about this incision. An eyelid crease incision is also one of the rare incisions used in the eye, where even if the suture gives way and there is a dehiscence, and then you don't really need to resuture because there is so little tension on the wound that you can actually leave it alone and it heals pretty good. The second thing is most people ask is what in a surgery for LPS is the scar going to be a problem? It never is because IV crease incisions are hidden incisions. I mean, the scar is very nice underneath, hidden in the fold. Sorry. How to clean the did you? Talking of proline, the second thing I wanted to share was that in LPS surgery, particularly a sling, you expect a significant lag of always pass of cross feature. Is it pulling the video? Cross feature will be passed from the lower eyelid and will help in preventing exposure in the early post-op period. Okay, cut the lady. So that is the advantage of the cross. And you are, at least in the first week, see what is happening there. All you have to do is put ointment and use to close. So that before they get used to how much exposure is there is pain from the surgery, we are expected them to show how to use the cross feature. Ointment? So that's the completion of the surgery. Okay?
It stands for maximum LPS restriction, but ultimately we do not go for that.
No. So that's what maximal LPS resection can only be achieved when you are taking the suture at the highest point of the LPS. But the highest point of the LPS is actually the Whitnall. So that's exactly what I did. The downside of this is while you get a reasonable correction, because the action is poor, lag off is a risk. If you would have taken it just short of the Whitnall, maybe she would have barely cleared the visual line. So we did this. But the downside is the lag off, and then we've taken the cross suture, and then we need to see how she's doing. So what I was trying to say is maximal LPS resection is a term interchangeably used with Whitnall sling.
So now finally what we did is the Whitnall
Sling, which is actually a type of, so any kind of sling is fixing the tarsus with a fixed structure. It's actually a suspension. Here we are using Whitnalls as a fixed structure to fix the tarsus. That's why it is called a maximal resection. Okay? Yeah. So it is pretty much the same. And I feel because she has a little ptosis in the other eye, even if we end up with final ptosis, 90% is undercorrection is a possibility. Overcorrection is very rare. So we will have something which will look reasonably similar. But had we done a suspension with, let's say, frontalis flap, there are relationships of how she uses the brow. If she doesn't use the brow very well, it may not transmit. The risk is a little bit in the sense that there may be ectropion, entropion, lid malpositions because the way it is pulling up. That's one. Second is, of course, fascia and all is completely a second side surgery with me. So I think she should do reasonably. I mean, and most likely you people would take a look at the post-op and let me know what exactly. But frost is extremely important for the first week. First week for the first week.
I don't know for now. Yeah.
No, it is what
Thank you again, Dr. Surya. This was a very good interactive skill transfer of maximal LPS resection. Fabulous. We'll go on to the next surgery in a while. It will be a bilateral entropian, which will be done under local anesthesia.
किडनी ट्रेनिंग नहीं क्या चाहिए estimate दे दो This one also great. 4 milligram per ml, 2 ml चाहिए. 4 mg per ml ଅଛି ना. नहीं कितने दिन में स्टार्ट कितने दिन स्टार्ट कर स्टार्ट टैबलेट तो गिलास आनो हाँ दो थे आप और आप नहीं बोल
এটা ওদের করতে দিন হচ্ছে করতে দিন এটা কারেন্ট বন্ধ হয়ে গেছে আরোটা পুরোটা চালু तो लाइट बंद यार हजमा করে হ্যাঁ এমনি লাগলো লাগে ঠিক করে আপনি মানে ভাগ ঠিক কথা বলছে হ্যাঁ डेस्टिनेशन कौन सेव है ना सेव तो नहीं थी सेकंड टाइम ये कर सेव आफ्टर ये कर हाँ सेव वीडियो आपले से छाड़ो नेट स्लो अच्छे कि नेट नु फिर स्ट्रीम बंद हला शॉर्ट के गला से लाइट
स्टेटस लाइव अछि
स्टेटस लाइव ଅଛି
स्ट्रीम बंद ହେଇଛି ତ ଏଥିପାଇଁ ବଫର ଖାଲି ହେଉଛି ଆଉ କେମିତି
ହ୍ୟାଲୋ
ଲାଇଭ୍ ତ ବନ୍ଦ କରିବାକୁ ପଡ଼ିବ ନା
हेलो हाँ कौन बोल रहा है हेलो हाँ हाँ दीदी कौन ओहो अच्छा अच्छा हाँ दीदी सेटा सॉर्ट आउट ओहो ऑडियो
उनका उनका हमें नहीं पता, ठीक है। हम लोग तो कल निकल रहे हैं। तुम लोग को क्या करना है, तुम लोग खुद में डिसाइड करो और सर को बोलना, ठीक है।
आप लोग कितने दिन के लिए नहीं
हम लोग तो तुम्हारा मंडे को नहीं कर रहे हैं ना, हम तो बोल दिए। ट्यूसडे भी नहीं कर रहे हैं ना, ट्यूसडे तो नहीं होगा, कोई ओटी नहीं होगा।
नहीं ओटी नहीं होगी, मतलब ट्यूसडे को वापस आ रहे हैं क्या आप लोग?
हाँ, हम लोग रात को आ रहे हैं, ट्यूसडे को रात को बैक करेंगे, मतलब शायद
ट्यूसडे को कुछ इवेंट है क्या? किसमें?
फोन तो फोन
चार दिन आपको दिया गया है, संडे मंडे ट्यूसडे वेडनेसडे ये तो
तुमको इसको पहले उठा, तो तुम लोग अपने में ड्यूटी सेट करो, पता नहीं
वो लोग भी तो नहीं रहेंगे, डिस्ट्रिक्ट वीक के फर्स्ट डे तो नहीं रहेंगे।
खुद में बात नहीं हुई तुम लोग का।
हमें नहीं तो बोलेंगे खाली मंडे का प्रोग्राम है।
अरे नहीं, इसको कनेक्ट कर दो, फोन करो, फोन करो। तो बात करो तुम लोग छः लोग डिसाइड करोगे ना कैसे कौन ड्यूटी करोगे। वो हमें भी नहीं पता था कि तुम लोग को पता नहीं है, तुम लोग बात करके कर जाओ सब कुछ।
मुझे नहीं लगता कि उन तीनों को भी पता है कि कितना दिन का प्रोग्राम है।
उनको पता नहीं है कितने दिन का प्रोग्राम है। लिप्सा को पता नहीं, लिप्सा रंजित मुझे पता है,
ये आगे मैम लाइव स्ट्रीमिंग होना चाहिए। तुम कनेक्ट की इसमें
स्पीकर
ये कनेक्ट हो
खबर ना इधर कॉल कर एटा स्पीकर रहबो इधर କଥା हेगे
हो तो रहे।
हेलो
हेलो
नहीं
हो जाएगा क्या? ये स्पीकर में डाल दो,
हेलो
स्पीकर में डाल दो।
Uh-huh. Okay, this is for the gaming group. So, our third case for today is an individual who's got bilateral involutional entropion. And he's got bilateral, so involutional entropion, there are three different components which are responsible for causing the entropion. Number one is eyelid horizontal laxity. The second one is vertical laxity. And the third one is the overriding of the muscle. So we'll have to correct all three to expect the correction of the involutional entropion. I'll start by giving a little injection, infiltration actually, along the lower eyelid. One pearl here is most of the time when you are doing the surgery, the moment you do your examination earlier, because the moment you give the injection, the entropion gets corrected. So what you need to do, how much you should ascertain before the surgery. That's one. Second thing is always give a little frontal nerve block. Now, how do you give a frontal nerve sensory block? Go right to the center of the eyelid. If you're using a syringe with a 26 gauge needle, it has to go right up to the hub. It is 24 halfway. Right in the center, between the rim, you go up to the roof. Hit the roof. The hub is almost there. Now hit the roof, come back, give the injection. And usually about 0.5 to 1 cc is enough. But if you are doing something like local anesthesia doses correction, actually the frontal nerve block works very well. Because it doesn't cause any motor problem, but takes away pain. Right. In this case, we don't need to give any upper eyelid but we will try to give as much in the lower eyelid. Once that is done, we just wait for the drug to take effect. And in that time, we can use a 40 silk lid margin suture. 506 silk is okay. Yeah, we'll do that. Do that. Marking, correct. Give me a forceps. So here I'm taking a lid margin feature which actually helps to give traction. You actually want to do it at the gray line. Yeah, so it hold on. Okay, actually we are done now. This is actually very fine body holder. Yeah. Really done. Good. Marker. Now in this, we plan to take a sub-severe incision. And where do you start? At the point of the punctum. Okay? You start at the punctum just underneath the eyelashes. Just underneath the eyelashes. How far do you go? Usually what I would do is, because we are doing actually a Jones, we'll extend it as a relaxed one even beyond the canthus. That's the right. Artery. Can we have the monopolar? Usually monopolar red is a bit of the on the blood osteocard. Okay. So there's the punctum there. So we start here. Now this is obviously the tip is more not very suited for eyelid. I think it will serve the purpose. Cutlery is which one is the cutlery? Go to machine. Is it okay? This is called Soxy. Oh, there, huh? So vanilla, huh? Okay. 20 is good. So what am I doing here? Skin, orbicularis. And just little you see that, that's process. Okay. Now the relationship here in the lower eyelid to is very similar to the upper eyelid, in the sense that position of the fat and the retractor. Just one needs to remember that the retractor in the upper eyelid is LPS. Okay? Lower lid retractor is the retractor in the lower eyelid. इसको extend कर दो. this is actually should be close to the septum. But particularly in older people, it may be quite challenging to identify because the fat is very, very atrophied. Okay. They don't make out very well in the lower eyelid. So again, I'll use a trick of the trade to identify them. Now you're supposed to take this further. Huh? What? Now we have a little bit of fat here. See? Okay. Yeah? We have a little bit of a fat there. And many more leaders. I think we are good. इससे टिक्के ये बताओ load का Now here we have the tarsus. Lower eyelid tarsus is only about 4 to 5 millimeters. Here we have to identify the. Ideally, there will be what are the structures here? Lower eyelid retractor, conjunctiva. Correct? Both of them. Over that, septum. So if you ideally just like the opposite of what we did in upper eyelid, go through the septum, fat, lower eyelid retractor. Then it was LPS. The thing is, because the fat is very LLR is the retractor for the lower eyelid. So that relationship is the same. But because the fat is atrophic, sometimes it is difficult identifying that. Okay. So, with this here, we take a little injection, and similar to what we did in the upper eyelid, we will do it here also. And we give it, take a look where we are giving it. Giving this in the underneath the conch. If I'm giving underneath the conch, then where is it going? Between the conch and the lower retractor. Yeah. Now,
Previously also you
same relationship. That's why I'm drawing the parallel between that. Now, Muller is essentially lower eyelid. Give me the figure. Now, conjunctiva mullus in the upper eyelid is used for a lot of times for surgery. Okay? Most of the times in surgery, at least in the lower eyelid, okay, you will not be able to differentiate between the conjunctiva, okay? At least in the upper eyelid, let's say when the mullus is something that we need to really look out for, it will be difficult to differentiate mullus from the conjunctiva. They'll appear all together as a layer, right? In the lower eyelid, things are that you will actually be just separating the retractor from the tarsal insertion. So what I'm holding is the retractor. And the space that was created by the injection, how to identify the retractor is because theoretically, if I inject it in the right place, which means only the conjunctiva, then the fluid goes into the only potential space between retractor. Right? So if I am inserting a layer and underneath I still have conjunctiva, then theoretically I should be in the retractor. It's like that. Okay? But this tends to unfortunately bleed. See, I've got a buttonhole small there, right? Not to worry, it just tells you that you've got to go more superficially to keep the conjunctiva intact. It's not here. Very. So this is the most important step of a stop. Is this step clear? And this is what we will placate to give vertical laxity correction. What I'm holding is the retractor. And inadvertently, I've already caused a small buttonhole in the conjunctiva. right? And as long as that remains there, the usual question I face at this stage is what happens if there are multiple buttonholes? Nobody asked this question. Multiple buttonhole is a problem. There's no problem as far as surgery is concerned. It leaves a bad taste in the mouth of the observers. It has to get gently hold. I think what we have here is this. So my left hand I'm holding this. And this is the septum. Okay? So whatever I hold here is the lower lid retractor which I want to like it. It really looks, and I think this is one of those surgeries where actually doing under a microscope helps. Magnify. Take it out. So this is the layer. Okay? Last confirmation is if you ask the person to look down, you will feel the tug. Okay? Just for the sake of checking that out, can you ask him to just look down a little? Tolko? See that moving down? Yeah, madam. Just look about the mouth with that. Let's do that. Okay, this is the layer we're talking about. Okay, now let's see what happens. This layer. We don't get it track to the come. This is the layer. Okay. Tolugu chaile. Upruku. Tolugu. Okay. That moves. Now sister give me vitral, vitral. Now this is what I have to placate. This layer. Okay. This is there. Now for plication of the lower lid retractor, remember one of the common complications of this procedure is overcorrection. So in our quest, I'll get the question into this place. Here actually less is more. So this is the disimpression. By taking it a little lower, I'm trying to strengthen the muscle. But before that, I will take skin muscle, lower lid retractor, okay, tarsus skin. You know, the picture particularly surgery over. Skin. Okay. Now I pass the slip knot just to show what effect. If I do that, see what is happening to the lid margin. It is everting, right? So I'll only pass the slip knot now. I'll tell you what. Again, same 6-0 vitral. So I took one suture centrally. I take another suture laterally. Does anybody else do 6-0 vitral? Any questions? The only difference is some people could take it as orbicularis, retractor, orbicularis, close. Now, so essentially the question is, why am I taking it through the skin? To give that advantage, because these are my cardinal sutures. If the patient goes into overcorrection, I can actually release the suture. Is this one? I can release that suture, okay, external suture through the skin and correct the overcorrection without taking the patient to 40. Again, skin muscle, retractor, mouth. There's the retractor. So identify, yeah. There. So the question I was expecting is, why didn't we do it medially? Usually for the cardinal sutures in involutional ptosis, we take a suture centrally and laterally. Avoid doing it medially. And that is done to avoid a punctal ectropion. So this one again, I pass a slip knot and keep it cut. Any up above this, yeah. Now with these two done, a little ointment. The surgery is actually not over. We've only taken care of the vertical laxity. Something fell down. Ointment? Right. Now comes to the horizontal laxity. Monopolar, you have a forceps with you. Okay. Now lateral tarsal strip. Okay? Xanthotomy. Somebody was asking me about how much to excise to form the tarsal strip today. Okay. So that's xanthotomy. Xantholysis, I hold it and then what? And as I do that lysis, my left hand should release up. See? So that's the eyelid. Now that has to be tightened for horizontal laxity. Okay? How to form the strip, lateral strip. Now first is ascertain how much of tightness you want. Now, this is the bone. I would think that I would mark here. This is how much I will make the strip, lateral strip, right? So steps is I take out the conjunctiva. One. Actually, scissor करेगा. Actually, एकदम suture stretch है यार. And then I remove the marginal strip of conjunctiva. We hold the conjunctiva, sorry, skin here, like I'm holding. And the tarsus separate to only keep the tarsus. skin can be excised. Believe it now? So now we have only the tarsus. Okay? And tarsus has to be fixed to the periosteum. Now this is the strip. And this goes in like that. Okay? That's what. Now here we usually would prefer a little tougher suture for a longer needle. 5O is what I prefer, Vicryl. 5O Vicryl actually. Costly the 5O. 40. You want the 40? Huh? 40. Oh, very much. So we use a 40 Vicryl suture for tightening this. Okay? After the horizontal tightening is done, then we will tie the vertical laxity sutures. Otherwise, what happens is you've pulled it, after that you can't pull it to the lateral. Okay? So the reverse works better. Do the horizontal, then fix the center. Okay? It's it. We want to it's challenging now. जो चादर है नई चीज अच्छा anyway let's hold and see. So what do we need to do? We mop, we take anterior to posterior, okay, of the tarsal strip, antero-posterior first. Next one is you have to take it through the periosteum. Usually this is easier with a needle holder. We will see what we can do. That's that. So I hope you can see. I'm trying my best to keep it centered. Okay. Fix the periosteum. Okay. And scrape against the wall and try to come out. Let's see. It's turning again. The needle holder worker was. Turn. It is open now. It's boro needle holder. No, it's a plate create difficult. Okay. Let's see with this. It's the periosteum. Coming out. Right? Sorry, I did a focus on. That's the needle. And one has to confirm. I pass that. And whatever is the loop, I hold that and see whether it is passing through. So this is Dita. Hold that. This is one. Sorry, this is one. This is one. Dita. Suture. Right. So the periosteum में pass करके बहुत tough लगेगा. Right. Okay. Now our periosteal bite is done. Antero-posterior bite was done. Periosteal bite done. Now it is posterior to anterior of the tarsal strip. that's posterior to anterior. One, do that. Oh, is this one? Either needle to lagi thi sir. Take a look at the upper eyelid को, just hold it. Hold it with your. The picture सामना को देखो तो सीधा देखिए. I'm trying to tighten this. See that? That's horizontal laxity correction. Correct? Okay. So what I'll do is hold this. Right hand. Take a loop. It out and put other end. Other end put. It other long range. The pass take this attention. Upper eyelid nochi. Try to pass that. Yeah, with a loop here. Then kori pariyo. Into kile na cheese wire kar jaye from the periosteum. So my suggestion is we'll cut it from here. Rather you just pass the and tighten the knot. After cut kariye baad क्या करो? Okay, so double loop. Take Vicryl. Vicryl will, moment it touches blood, it will not pass very easily. Now take two loops, hold with your hand, and while somebody else is holding the upper eyelid, tighten it. Which means you titrate how tight you want. This is a trick here. Why? If you make it too tight, it will actually become, it will turn in. The lashes will turn in. Try to do that sometimes. When you push a lot, it will turn in. It has to be just right. So usually I see it as I will feel and how taut it is. And I see it is quite taut. See that? That is how you. Once you have confirmed that yes, this is tight enough, confirm. Look, give the final silver. Not. Take one more. Yeah. Tight first. Okay. You do that. Tight. And then again take the knot, tighten it over it. Otherwise at a higher point, it will come and form the knot. Vicryl, once it forms a knot, very good memory. It will not slacken at all. The last one here. There. Okay. We have completed the lateral dorsal strip part. This one. Okay. So this is done. Now we'll just clean this and take care of the horizontal is done. Vertical we will do. So now we don't need this suture. We can take this out also. Confusion is too many sutures is confusing. The suture of the other eye use kar. Now needle holder please. The Deepak kamote kaam karo. It left हाथ रे pull करिए रखो so that people can see. You can see the sutures. This is the central. This is what we had done earlier. Check it. So the retractor. Okay. I tighten it now. Now, so this one is what I would call is my cardinal suture. Now, later when I've done a skin closure, how do I identify that which are my cardinal? I keep this long. Make sense? The other ones I'll keep short. Because tomorrow when I have to open, if there are so many skin one also, I'll not know which one to do when. The same Lateral one also. We didn't take medial anyway. Right. Right. Cut long. Now I take a shot. Huh? Yeah. Shot. Now Michael. Let's clean this up. So take the scissor with you and cut it short, really short, these ones, so that they are easy to identify. One, cut. And actually, once the skin closure is only for the sake of closing the wound. And if you think there is a lot of extra skin, you may want to excise some skin also. Cut. This is Jones. No. You know what? Jones, if you see, Jones takes care of all three components, right? So if you go strictly by definition, right? So lower lid retractor, plication, horizontal in the form of lateral tarsal strip, or you may also do a pentagon or various ways of horizontal shortening. And because you're taking a subciliary incision, is all sort of covered with the Jones. Right? Short. And this is really something which takes care of in the long term. Very few recurrences if done well. Some people say, can you get away by only doing lower lid retractor plication and not the horizontal? I personally feel that if you can ascertain a group of patients who don't have any laxity of the horizontal, that means cancer is absolutely fine. You may get away by doing that, but that is a very small group. Sometimes you will notice even young people come with entropy, which are more vertical laxity, and horizontal laxity is not there. There you can get it done. Okay, clean So I have actually two sutures which are long, which is one here and one here. We can actually take one more Vicryl here. Then that takes care of the involutional entropy. I wanted you to show in the other eye one everting suture, which is actually a bedside technique to take care of, and then go on and cut it and then go ahead with the surgery for a definitive repair. Okay, Vikram? Because I feel that the skill of being able to do a everting suture is very helpful. Why? Because sometimes you may face that odd patient that you cannot call them to the hospital. And entropion is not something which you can let go. Entropion you can leave. Not interested, it will cause watering first. Entropion can cause serious damage. That's done. Right side, Jones.
Right, right?
Yeah.
same person would have a erotic suture in the left side.
Not really. What I had in mind was everting suture is a temporary. So just to give the benefit of, while we can do the everting suture to show the result, we will actually cut the suture and then go ahead and choose. Yeah. It's like, the only problem with an everting suture is it is not definitive. It is likely that it will recur. हमको उधर 300 वाइकल डबल आर्म मिलता है डबल आर्म माने दीपड़ा का नीडिंग क्यों मैडम ಇಲ್ಲ ना पिक्चर वाइकल ओके I think Alka would like to make a move here, right? So that you reach before sundown. Okay. अब मैं बाप पे टिके इंजेक्शन दो चू हे गला टिके इंजेक्शन दो चू It's quite in the other side actually. But if you give the injection earlier on, I don't think it works that long. So again, front tension. Oh, made a mistake. That's the advantage would have been injection legally, na? So correct you. But I'll show the technique, and you'll be surprised how beautifully it corrects. Right, just two sutures. Correct. Sorry about that. Actually, say vital again. Double up. What happens is when you've given the injection, even the expression of the muscle goes away. The overriding is happening where the muscle is acting one over another. Right? So another simple way to take care of entropy if you are unable to do even an everting suture on is to give Botox. The overriding will go away. Right. So this is one arm. All you have to do is put biceps. For everting suture, hold the upper eyelid, go to the phonics, open, and come out near the eyelid margin, as close to an image. Inside of the you come out on the skin side. So that as close to the that's one. I think the effect will still show. It's only that it would have a cross entropion would have corrected. But there was under one. Second one. These sutures. Now let's see what happens. Okay. Only for the sake of demonstration. Am I centered? Okay. Am I centered? Whatever. So I stick to. Yes. Now, the upper eyelid too, and now just hold it with your right hand. If I were to use a loop and tighten it. Okay. See what happens to the lid margin. See that? If you were to take two of those sutures in the right spot, your entropion will be bang correct. And then don't remove the suture. Let it degrade on its own and cause the scarring. That's what you want. But the textbook teaching says probably 12 months or later he'll end up with the same. Because they're not corrected the main problem. So, we don't want to him to find that he did do a good job with the other right. But, yeah, this is a very common one. It's not that is all right. It was okay. This margin.
Otherwise, removal of the black heads like in this picture,
No.
not enough restriction.
No, actually. I mean, these ones to remove, no, the coefficient or cheap, it is skin. Then skin is what a defect to you. Ah, आपका? That market actually. Yeah. Okay, monopoly. So, let's just. There is a question, okay. Okay. Okay, drag storage. कितने कॉन्क्रीट बड़े हुए खाली कर देंगे कंप्यूटर खाली कर देंगे कटिंग कर Okay. Say it again? When you hit the tassel plate, yeah, the tassel plate you have to actually essentially detect down. Not here. Okay. Injection. Just a minute. Inject. Put a balloon कर दिया. Okay. Good. Yeah. Um, okay. Yeah. Now look at this side. Here, full thickness. See there, right? You don't want to be there. So what do? Try to direct it more superficial, and then create a plane between the yeah, yeah. Um, yeah, this way. Come on. It's only getting worse. Look at that. Let's try it. So whatever Kochi may be able to do, this separation between the two, I feel only a of very fine Westcott stuff. Usually a pottery will go difficult to control to go such a fine deflection. So if you have a larger buttonhole, look at that, it's just getting worse. Yeah. Okay, here you have again. Let's do a little retraction of this layer. Yeah, there is an eyelash, correct? It's हो गया but you still should have a posted it a hold karo up good that was the step one and here the same C start right that's the one mark again on the inside I still want to try and see if I can separate between the two layers mark okay this is the low layer retracted switch up 6 Viker. This is the retractor. Here. Yeah. Right. You take all both of them, you want to exactly what you must do. They might be it. There. Okay. One. Two. And cross this. Pass through and pull. You want to release this one. There. everting. In fact, the eversion is more than we need. So when we are tightening this is now a step. Tightening it, I may want to be a little gentle on this feature, a little bit of a hang back kind of thing. Now let's cut this. This one. So the reason why this is evoting more, I already corrected by taking a little less because I've lost some muscle at the edge, but I think that is not enough. Mark. Cut. Yeah, yeah. So, two cardinal. There also we took two cardinal. Yeah, two cardinal, other skin. Same thing we had done up there also. Then we have the ointment. Actually, well, actually, that's something I personally I would never take medially because there's a high risk that you will end up with a punctal ectropia. See, it's less forgiving medially. A little bit of ectropion in a corrected entropion, you could end up with a lot of symptoms, right? But the other two, you actually are, it's much more forgiving. Second, with the horizontal correction in the form of LTS works very well. There are even some who say that you don't need to do the vertical at all. Just do lateral dorsal strip, it will correct. Okay, monopolar. And Arnab, you will have a tooth forceps. This one you hold. You will feel the release. So I'm doing epicantus. Using a monopolar, be very careful of the ocular surface. So canthotomy done. You will hold it, right? Hold it. And when I do this, you will feel the release. So that is cantholisis. One should not mix up one for the other. Canthotomy without a lysis is of no value in correcting a orbital compartment syndrome. This is going to help me form the strip. So I try to take it there and decide where, how much I'll take. Mark. And let me not use the monopolar just for the benefit of the audience. I will use the first is removing the marginal. Right? You see? That's actually, it's on the margin is less skin, more conch. Right? Then separating skin from the postulamina. I only want tarsus. Right? So based on that, actually you can remove that. Then this has to be removed either with a blade or if you have a monopolar advantage one, just take out epithelium. If you leave this will all go and form an implantation. Epithelium implantation, right? And sometimes even a cyst. So that's taken care. And that is what is going in. Why would you? Why? Yeah, so that's the reason actually. So this will go underneath, right? Now is the time when we pass that fix feature. I actually have not, but I think it is not so much to excise. If I excise, I may have to do a little hang back. And the other side, if you noticed, here, it is almost up to the tarsus here. Other side, there was tarsus and there was some loose tissue. So I always wanted to take tarsus, so I excised the loose tissue. But if you have a lot of laxity, you can take out. Not a problem. This is the difficult one in always in LTS. And if you were to ask me what suture works great, in my hands, it is 5-0 vital which works. It's a little longer needle than 6-0. 6-0 to pass through the periosteum and coming out is a little difficult. 5-0 with its needle comes very great, nicely out. Okay, so anterior to posterior. And then mark. Shift on the inside. Scrape along the inside. And try to engage the periosteum. What is the periosteum called here? Huh? Periosteum over the Wittnau's tubercle. No. This is not. Okay, not Wittnau's tubercle is a little more on the inside surface of the lateral wall. Right? You are trying to simulate that by doing this. But you are actually catching the lip of the periosteum, and the periosteum at the edge is called arcus marginalis. It's tough, right? You're just trying to pass it through this. And how do you ascertain that? When you pass, like I had shown, if it is through the periosteum, hold these two. It will not budge. Right? The same thing we have done inferiorly in FFS. You know, the canthal tendon would be essentially what happens to the canthal tendon, like you would think. And the canthal tendon is a Y, right? And goes and attaches to the Wittnau's tubercle. So when we are splitting the canthal tendon by doing a canthotomy, then we are only cutting the inferior crux of the canthal tendon. Okay? So we are not doing anything to the upper one. It's still attached. So by doing this, we are again reattaching the lateral tarsal strip of the lower eyelid to the periosteum on the inside surface so that it closely opposes with the globe. It is trying to simulate that normal anatomy. So not exactly the same. Now let's see if you are feeling the right thing. You are holding. We are yet to take posterior consideration. The needle holder out of the left. The needle holder. I think around 45 minutes. Like this, what you do is either सीधा टिके देखो तो सीधा देखो तो सामने को साइड को नहीं सीधा देखो this one no that's the smaller one with the longer lip one more full no that's loose look at the lower eyelid so what is happening is because it is acrylic it is getting stuck to the blood common problem which means that we have to we may not have to sacrifice it. We definitely have to take out the knot. Mark color is So if it is that much, now we think that we will actually take only of one knot, one slip. Okay? And then see if we can. Got a contour, upper identity also. Here, the tighten. Okay? Okay. White will be very careful with the knot. It is not uncommon for it to get entangled. The moment it touches blood, it gets stuck. Sometimes when you feel that there is a knot, it may actually be loose. Having said that, once Michael you have passed the knot, nothing else. Right place, there we take care of the right. Right? Okay. We have it. Did you hold up? Let's clean the get notching. Yeah. Back this area a little bit. Then we have one suture here, one here. Okay? No. Yeah. Get into correction. Little more gentle. Huh? We had realized that when we passed the first one also, that it was going towards overcorrection. So I second usually monthly. Now here there is something now because you're going to canthrotomy. Ideally, we should reform the canthus. What I'm doing is I'm passing it from the gray line. And remember, I told you that upper crux is not affected. We only divided the lower one, right? So the upper crux is intact. We pass from the upper. This is forming the new canthus. Based on that, we form the acute angle again of the vessel canthus. Okay. Comes loose, what happens is it tends to form a rounding of the vessel canthus. That is what is described. Then once we are done here, we take our sutures, form the take the suture and keep it underneath. Just like we do for lead margin sutures. Yeah, this one is continuous. Which one? Actually, theoretically, interlocking sutures work best when you have a lot of tension in the wound. Okay. And for eyelid surgeries, that applies only for something like maybe a large reconstruction or something like a brow pexy, direct brow lift. In that kind of a scenario, you can take intervention because there is a lot of tension. But in eyelid, I don't think it should be so much of a need. These are small, small. But so towards the end of this, we are just taking smaller and we are intentionally keeping this suture small so that we can identify it from the cardinal spots. I think we are the last bit. It should not be like a watertight closure. You can be a little sparing. So there is one suture towards the other.
So he comes to name the surgery, is it?
Yeah. That's the final result, and we take out both sides. So, will it come into focus? This is directly uttrile focus holds. So this is one. This is correct. This is the second.
And a bilateral entropian correction. It was involutional entropian in both the eyes. And thank you again, Dr. Surya, for such a beautiful demonstrative surgery that we saw and learned a lot from you. And that finishes the surgical part of the workshop. Thank you so much.
Thank you. It's always a pleasure.
Okay, could you end the live stream? Yes. I will and put send.